warm welcome to today's ICS webinar on shingles prevention in COPD and asthma. This is a very, very important topic. We really need to know about prevention of shingles, and we in fact also have the Shingrix vaccine, which is available in our country, which very few people know about. Every guideline, whether it's GINA, whether it's Gold, or whether it's vaccination guidelines across the country and international, everybody is actually recommending the use of vaccine, Shingrix vaccine. However, not too much awareness is there, and therefore I feel it's a very, very important topic for today, because we've got fantastic speakers, we've got amazing faculty. We have Dr. Vivek Nangia and Dr. Dhar, who are going to tell us everything that we need to know about this very important topic about shingles prevention in patients of COPD and asthma, and also about the use of Shingrix vaccine in other high-risk individuals where we ought to be using this particular vaccine. So I'm myself really looking forward to learning so much today from this fantastic faculty on this very important topic. I would really like to thank our academic partners, GSK, for being pioneers whenever it's come to spreading education. And I'm also so grateful to Dr. Yashpal and Dr. Ashfaq for all the time being available and making sure that the webinar turns out to be really a huge success. A huge big thank you to our Indian Chess Society, our president, Dr. Sandeep Salvi, our secretary, Dr. Dhar, and our entire governing council of Indian Chess Society for their commitment in providing fantastic webinars week after week on every topic, which is going to actually make us improve our practice. So with this brief introduction about our topic, I'd like to first introduce our first speaker, Dr. Vivek Nangia. I think you can remove this. I think people know me. I'm Dr. Amita Nene. I head respiratory medicine at Bombay Hospital. I'd like to talk about Dr. Vivek Nangia, who doesn't require any kind of introduction whatsoever. He is the Chief of Pulmonology, Max Healthcare Cluster 1. He is the Principal Director and Head Institute of Respiratory, Critical and Sleep Medicine at the Max Saket Hospital in New Delhi. He is a founding chairperson of Pulmonary Intensive Care and Infectious Diseases Academia. He is the member of Governing Council, Hospital Infection Society, India. He is a founder member of one of its kind society in India dedicated to adult immunization called the Forum for Adult Immunization Towards Health. I mean, faith. Amazing. Who better than Dr. Vivek Nangia telling us about this? And so very modestly, he's not written about so many of his other positions that he's holding. He's a vice president of Indian Association for Bronchology. He's a DNB teacher. He is really a pioneer when it comes to interventional pulmonology. He's a great teacher, a brilliant academician with so many publications and book chapters, and most importantly, a very, very dear friend of mine. So with this brief introduction, I'd like to move on to Dr. Vivek Nangia. Vivek, over to you. Please start. I think I'll introduce Dr. Raja once his talk comes. I think that'll be better. So can we please display the slides of Dr. Vivek Nangia, please? I think we've lost Dr. Vivek Nangia.
Yes, ma'am. I think we lost him.
Here till now. I'm really sorry. I really apologize to our audience. We'll just wait till he joins back in a minute. So then maybe we can just put the slide of Dr. Dhar. I'll introduce Dr. Dhar till Dr. Vivek Nangia joins back. And can team GSK please call up Dr. Vivek Nangia?
Yes, ma'am.
Okay. So while Dr. Vivek Nangia rejoins, I'd like to introduce my very, very dear friend, I would say my best friend, Dr. Dhar, who really requires no introduction whatsoever. He is the Director and Head of Department Pulmonology at a CK Group of Hospitals at Kolkata. He's the Director Research and Educational National Allergy Asthma Bronchitis Institute, Kolkata. He's the Director Hermes Exam Asia, and he's a European Diploma in Respiratory Medicine. This is a very, very proud thing about Hermes, because we all had to go to Europe to give our herpes exam, but thanks to Dr. Dhar, we can write Hermes exam in our own country, which is great. He is the Secretary of Indian Chess Society. He's the Joint Secretary of Indian Academy of Allergy. He's a Director of Asia Pacific Alliance for Control of Influenza, founder member of Southeast Asian Academy of Sleep Medicine, 162 international and national publications, 23 book chapters, so much more. I can keep on talking about Dr. Rajadhar till tomorrow. So I think let me just cut out. You can read. He's got the Dronacharya Award for Excellence in Continuing Medical Education in India. He's got Indira Gandhi Gold Medal for Outstanding Individual Achievement in Medicine. He's a Joint Secretary of Indian Association of Bronchology. And he is actively participating in our protest against what has happened in Kolkata. So with this brief introduction, we have Dr. Vivek Nangia back with us. Welcome, Vivek. We lost you in between for a minute.
Sorry,
So
just
we
at the
just
crucial moment it got dropped.
yes,
But
sorry.
thank
No,
you
I
so
mean,
much, Amita, for those kind words of introduction. Really, I'm really grateful to ICS for inviting me this evening, GSK for hosting us. ICS has been doing very good work, especially under the leadership of Dr. Sandeep Salve, Rajadhar, and you yourself. So it's really an honor to be associated with you all. And without wasting much time now, so I'll just start my presentation for the evening to talk about vaccines. You know, how important are vaccines in our lives, in the lives of the patients, especially those who are immunocompromised. But is it only restricted for immunocompromised? You know, I remember there was a time when about a few years back, I was looking for a picture for about adult immunization in India. And guess what I got was an adult holding a child and immunizing the child. That is all that you could get about the adult immunization. There was nothing beyond that that people would speak about as far as adult immunization is concerned. But what we forget completely is that the biggest research, the biggest gift that scientists have given the mankind for as far as prevention of diseases is concerned, especially infectious diseases is concerned, it is the vaccines and nothing else. If there's one thing that can prevent a disease, is vaccines. But unfortunately, we in India don't give it as much importance. Of course, COVID did wake all of us up, but that was also a lot to do with the government initiative and pressure from the government to get the vaccination done. I'm not sure if it was optional, how many of us would have gotten it done or not gotten it done. So if you actually see the history, that with the exception of safe water, no other modality, not even antibiotics, has had such a major effect on mortality reduction and population growth as vaccines have done. So there is so much of importance that vaccines hold in our lives, but unfortunately, it's always underplayed. What happens is that, you know, our vaccinology is all focused on the pediatric age group. The pediatricians are very, very prompt in getting the children, patients of theirs, the pediatric patients of theirs vaccinated in time. But we as adults tend to ignore it for some reason, probably because we don't have that conviction ourselves. But what we need to know is that as we age, there is a phenomena called immunosenescence, which basically means that the immune response gradually goes on reducing. So in a child, when you have the immature newborn immune system, they develop during the adolescence and into adulthood. So the immune system enhances a bit. And then as we age, again, there's a decline in the immune system, making us more prone to catching infections. So with aging, there's a decline in the functionality of the immune cells, in terms of the replicating capacity of the T cells, in terms of the hematopoiesis, there's a decline. There's a total and naive B cell levels decrease, clonal diversity decreases, efficiency of the antibody response decreases significantly. NK cells stop producing chemokines. There's a reduction in the cytokine production, reduction in their proliferative capacity, reduction in the phagocytic and the chemotactic capacity of the neutrophils. And of course, even when we see the organ systems in the lungs, there's a decline in the ability of the cilia lining to function. So it is not able to clear the mucus and the bacteria from that. The microbiome diversity reduces in the gut. The muscle formation reduces. Cardiac wall's strength declines. And there's also a decline in the myelin sheath integrity. All these things are very, very essential in the maintenance of the immune system in an adult, which unfortunately declines. And now what is happening is that with all this, the kind of lifestyle modifications and early detection, better diagnosis of various diseases, especially the chronic diseases, there has been an increase in the longevity of the humans all across the globe. In early 1900s, the countries had a relatively high proportion of children. And now the life expectancy is anything between 60 to 65 years. I think India expectancy is about 72 years. So there is an increase in the population of the elderlies now. So we are actually becoming top heavy. And it is estimated that by 2015, almost 16% of the Indians will be over 65 years of age. Probably we also by then would have reached that age. And just about 5% would be under 5, so probably our grandchildren then. So increasing age is also associated with a higher risk of chronic health diseases. And of course, we all know that with age comes the diabetes, the chronic lung diseases, the cardiovascular diseases, hypertension, bones and joint diseases, all these increase in the elders. If you look at this graph, which categorically shows that there is a significant rise in diseases in the 60 plus category, in this entire category. So one, the population of the elders is going to be increasing. Second, that there is going to be an increased burden of these chronic health conditions, which we will be facing in times to come. And it goes without saying that the only way of protecting all these vaccine preventable diseases like influenza, pneumonia, shingles, hepatitis, tetanus would be with effective vaccination. Pani dena, please. So therefore, it is important to strengthen the immunity during the immunocensus. It reduces the serious health complications, hospitalizations, and even death, particularly for the older adults. And vaccination also helps in building the herd immunity. Herd immunity, I'm sure all of us are aware that it spreads from individual to individual. So if there's a large population which has been vaccinated, then even if there's a small percentage of people who have not been vaccinated, they would also benefit because the transmission of disease would be significantly lower. So the vaccination would also reduce the transmission of infectious diseases. There are, of course, other factors that we always keep in mind and tell our patients to follow about the healthy eating, involving themselves into physical activity, into smoking cessation, screening of health conditions, hygiene. But we all know that these things only are the tip of the iceberg. Many people would follow, most people would not follow any of these advice and would continue living the way they do, making them prone to catching all these kind of infections. Therefore, vaccination is one key element that can actually change the lives or the health conditions of the patient. These factors, of course, are dependent on the individual to follow or not to follow. But my experience is that over the years, what you would have seen, that people do say that, okay, doc, we'll go back and follow this, but it usually doesn't happen. How many of your smokers have quit smoking unless they developed an advanced COPD or developed a cancer of the lung? Hardly any. How many of your patients really go in for screening for health conditions or annual health checks? Hardly any, unless it is mandatory by their companies or by their employers to get it done. Otherwise, hardly any. Hygiene, yes. Hand hygiene, yes. As we see now after COVID, has become really very common and very popular. We see people carrying these in their pockets these days. But then again, how much of that is effective and how much of that is used is another question. But despite all this, despite knowing that the vaccinations are very important in prevention of vaccine preventable diseases, there are still lots of barriers to the adult vaccination program. And the first and the foremost is we ourselves are not aware about all these vaccines that are available. As Amita said right in the beginning, Shingrix vaccine is a new vaccine that has been launched for the last 2-3 years now, I guess, in our country also. Yet, not many of us are aware when to use, how to use, why to use. Then again, what is important is the conviction. You know, if we have the conviction, only then would you use it. So first of all, we have to check. The recommendation is to be given, Shingrix vaccine should be given to everybody over 50 years of age group. Have all of us taken it? I don't think so. There's also, of course, we tend to blame that, there's no adequate surveillance data that is available to us. But then again, Shingrix is a viral infection. If chickenpox is common in our country, why would Shingrix not be? Because it's the same virus that is causing this infection. There are lack of national guidelines. Yes, there are, because I don't think it's a priority. Adult vaccination is still not a priority with the government of India. They have greater things to look at. But I am fully aware that there are certain projects which are being taken up by ICMR right now, which are looking into the adult vaccination program also. And Raja has also been part of some of those meetings that I've also been fortunate to attend. And the biggest drawback is that we don't have any vaccination cards for the adults made yet. There's a total lack of coordination in the adult vaccination programs. And treatment has always taken precedence over prevention. Despite knowing it from childhood that prevention is better than cure, but we as physicians tend to ignore that completely for some reason. We focus on the treatment rather than on prevention. How many of us spend that 5 minutes extra to tell the patients that vaccinations are more important and should be taken on a regular basis? Costs, we always blame the costs. Costs, I would say, is very, very relative. It could be, if you're able to able to prevent a major illness, a hospitalization. If you talk of Shingrix, then if you're able to prevent post-herpetic neuralgia, then the cost is adequately justified. It is not just the post-herpetic neuralgia. There are so many other complications that can occur because of shingles. So if you're able to prevent those, cost is absolutely justified. And of course, there are sometimes when we are not aware of the recognition of the benefits, efficacy, and safety of a particular vaccine, so we don't use it. So what is very important is to make the healthcare physicians aware of the vaccine and the benefits of the vaccine per se. So a doctor's recommendation has a strong influence on the patient's decision. Your 2 minutes extra being spent with the patient to explain the benefit of the vaccine would go a long way. 71% of the patients get vaccinated when a healthcare physician recommends it strongly. They would not ask a second time. Yes, there are people who are resistant to vaccines. Those kind of people would be there everywhere and you can't really force them. But otherwise, I feel if you tell them to get the vaccination done, maybe they don't do it the first time. The second time when they ask you again, and they may ask you a couple of more questions that why they need to get it done and how you can justify the increasing costs. But it isn't so difficult. Usually the second or the third time, they would take the vaccination. There are various vaccination schedules that have been brought up according to the age bracket. The 19 to 26 category, then 27 to 49 years, 50 to 64, and more than 65 years, in which the influenza, Tdap, MMR, varicella, zoster recombinant, HPV vaccine, pneumococcal conjugate, these are all essential vaccines from our point of view. There is one which is much, if you go to the CDC guidelines, there's so many other vaccines also included in it. But these are some vaccines which are very important from our point of view in the Indian settings and should be used as and how indicated. So one way is to divide them as per the age category, and the other way is to divide it according to the immune status category. So if there's somebody immunocompromised except HIV, like somebody has undergone asplenia, post-splenectomy, or is on chemotherapy, is on steroids long-term basis, immunosuppressive therapies, for them, the number of vaccines indicated would be different. And HIV again decided on which vaccine is to be given and in what series. Hemodialysis would be another category where you would want to consider giving them a vaccination. So to sum it all up, vaccination is the need of the hour. Immunization is one of the most effective public health measures to prevent disease, but vaccination rates in adult population still remain below the targets. A doctor's recommendation has a strong influence. If recommended, 71% of the patients would follow a vaccine schedule. Patient and physician attitudes about vaccination may be very important and determinants of the adult vaccination rate. So unless that conviction comes within us, you will not be able to prescribe the vaccine to your patients. Timing and spacing of the vaccine doses are very important, so we need to know all of that. And the healthcare personnel should follow routine infection control procedures and evidence-based pharmacological, physical, and psychological pain management strategies when administering the vaccines. Children and adults often need more than one vaccine at the same time. So we also need to know which all vaccines can be combined and be given together. So with that, I'd like to thank all of you for joining in this evening and hand it over back to Amita to take the proceedings of this webinar forwards. And I guess we'll have the question answer at the end after Raja's talk.
Thank you, Vivek. This was a fabulous talk. I think it's just so very important to know that though we like to believe that we are really healthy and fine, we are growing older, and so is the immunity coming down, and the memory of vaccine and infections is gone, and therefore a booster dose is absolutely a must. And I basically feel that there's so much of awareness in our country for flu and pneumonia vaccines amongst us pulmonologists, but how many of us are actually giving the Shingrix vaccine? So I think this is a very, very important talk telling us why it is important that we definitely make sure our patients are vaccinated. We spend time telling our patients about it. And now let's move ahead. This was fantastically spoken. Vivek, thank you so much for a brilliant talk and loads of information. Thank you very much. Now I'd like to invite none other than Dr. Dhar, who I've already introduced earlier. So basically, he's going to talk about something very, very important, the prevention of shingles in pulmonology practice, which is so important for each of us to know. And who better than the Raja of Pulmonary Medicine, Dr. Dhar, telling us exactly what we need to do and we don't need to do. Over to you, Raja. Thank you.
Thank you very much, Amita, and great talk by Vivek. And before I start, I cannot stop myself from saying how enthusiastic you have been in arranging all the Indian Chest Society webinars, and absolutely kudos to you for the efforts you've made to put together these series of webinars that we have as a part of an Indian Chest Society initiative and being training and education leaders for Indian Chest Society. A big thank you to GSK for putting this together. Can I just ask the GSK team, can I share the slides from my side, guys? Is that okay? I have reduced the numbers a little bit, Ashfaq. So if you allow me, I'll... they're not edited, they're just reduced in number.
Yes, sir. So you can control the slides from your end, sir.
Thank you. Thank you. Are the slides visible? Yeah.
Yes.
So I'm going to speak. Thanks. So I'm going to talk about shingles prevention in pulmonology practice. That's the remit given to me today. And just to say that, like Vivek, this program is being sponsored by GSK, and the slides have been provided to me by GSK, and I'm receiving an honorarium for speaking today. That's my conflict of interest. But the thoughts that I'm going to share with you, what I'm going to speak about, are my own thoughts and as a part of my own academic initiative. So that was my conflict of interest bit. Let's start off with a bit of basics. So as you all know, we're talking about two disease processes or two manifestations of diseases caused by the same virus. And we are talking about varicella zoster virus, and we are talking about herpes zoster. A lot of you listening to us today would have had primary varicella infection or chickenpox. It occurs in childhood. It's a generalized vesicular rash. In some people like myself, have it in adulthood, and the manifestations are far more florid. They're far more severe when it happens. Chickenpox happens in adults as compared to what happens in case of children. All of you know that varicella zoster virus infection, so chickenpox, normally does not recur in humans. However, the virus lies latent in the dorsal root ganglion and stays there for a prolonged period of time. And this happens in 90% of population of people who have chickenpox. The reaction of varicella is the form of herpes zoster. It can reactivate at any time in later life. And as we look at going forward, the higher the age, the older the individual, the greater the number of comorbidities, especially respiratory, the greater the chances that you have a reactivation. The manifestation, as you know, for herpes zoster is that it causes a dermatomal rash and there's a lot of pain associated with the rash, and then even after the rash, which is called post-herpetic neuralgia, and I'll come back to this in a bit. So this is the disease course that you see, the symptoms and disease course for herpes zoster. So the prodromal phase, which is sort of for 4 days to 2 weeks, has symptoms of a viremia, a viral infection. So you get headaches, photophobia, malaise, etc. There's some amount of pain where the rash is, and there is fever. The fever is normally low grade in nature. In the acute phase, which is between 2 weeks to 4 weeks, you get a rash, which we said was dermatomal. Hence, by definition, it's unilateral, it's vesicular, and there's a lot of pain, irrespective of where it happens along the distribution of the rash. Some of these rashes become pustular, so from vesicles, they convert into pustules. And then you go into the subacute phase, which is up to 3 months, where the lesions crust and resolve over a period of time. In about 60 to 70% of the population, that's the end of the disease. However, in about 5 to 30%, depending on what sort of population you're looking at, you get a condition which we have described before, which is called post-herpetic neuralgia. This often happens months or even years, lasts for months or even years after the subacute phase is over. If you wanted to define post-herpetic neuralgia, it's neuropathic pain that persists for more than 90 days after the onset of herpes zoster rash. I want you to look at this picture. You see the scarring, the pigmentation, the fibrosis over the skin, the fact that healing has happened, but healing has happened involving the nerve roots there, which is responsible for the neuralgic pain that is associated with this disease. The next question to answer is which bit of the body is the most affected by the rash? So the most affected dermatome, what you see in the pink in that pie at 56%, is the thoracic area. That's by far the commonest. And then you have the cervical and the cranial part, which is somewhere between 10 to 15%. And the rarest is the lowest portion, which is the sacral area. The organ-threatening part of herpes zoster is when it affects the eye. So you can have the second, the third, and the fifth cranial nerve affected. Because the ophthalmic branch of the second nerve is affected, you can actually develop blindness from having herpes zoster. So that's the organ damaging effect of herpes zoster. The other parts, and you see that on the photographs there in front of you, is mainly about a dermatomal rash, which is healed with scarring and results in a lot of post-herpetic neuralgia where the rash has happened. What are the complications? So one, we have talked about 5 to 30% of the population suffer from neuropathic pain, which happens more than 90 days after the subacute phase. The other complications are very important, but are rarer as compared to post-herpetic neuralgia. The very important life-threatening complication is the vascular complications of herpes zoster or post-herpetic phase. So the vascular complications are stroke, transient ischemic attacks, myocardial infarctions, and other cerebrovascular diseases. The next one is neurological. All of you would have heard of herpes zoster encephalitis, meningitis, this nerve palsies that we spoke about. When it affects the ear, the seventh nerve, there's Ramsay-Hunt syndrome. And there are other neurological complications, but again, happens the small number of patients, but is severe complication. We spoke about organ-defining, organ-damaging complication in the form of herpes zoster ophthalmicus, which happens in not a small number. It's 1.4 to about 16% of patients. But eye-related complication, including the neuropathic pain, happens in a much larger number, somewhere around 30 to 78%. So about 50 to 60% of individuals would get affected because of herpes zoster ophthalmicus with ocular complications, which is not necessarily blindness, but other complications of the disease. This slide shows you the global epidemiology of herpes zoster. And I put this up for two reasons. First, the fact that across the globe, the number of patients affected is almost uniform. You can see the numbers, the various countries, mainly countries from Europe and the US, along with some Asian countries. You can see Japan on that slide. But the lines go parallel to each other and overlap each other significantly. The other bit I want you to see is the upsurge. The fact that the disease increases in number between the age of 50 to 60. So post 50 and around 60, there's a huge upsurge in the number of patients, irrespective of which geographical area you're looking at. What about comorbidities? So like other viral infections, I'm sure you've heard Dr. Vivek Nangia speak about influenza and pneumonia and comorbidities. So herpes zoster is no different. You can see a list of common comorbidities that affects the risk of herpes zoster. And you can see that boxed on there are the two respiratory complications. There's asthma and COPD, both of which increase the risk of getting herpes zoster. With the more chronic disease, the more disease which affects the elderly, more COPD, having a higher risk as compared to what asthma does. The other important fact on the right of that slide is that multiple comorbidities multiply risks. So if you have 4 comorbidities, and I want you to look at the blue bar on there, where you have a combination of diabetes, COPD, cardiac disease, something we often see in our elderly patients with chronic diseases. The risk with multimorbidity increases significantly as compared to one risk factor, which is, for instance, diabetes. So diabetes does increase the risk, but 3 comorbidities causes much greater risk as compared to one comorbidity. Let's come to the respiratory part. That was the remit given to me today. So both COPD and asthma, we've seen from the previous slide, increase the risk of herpes zoster. How does it happen? I won't take you through the pathophysiology of this. I think suffice to say that the mechanism by which the risk increases in COPD and asthma is slightly different. So COPD enhances susceptibility to herpes zoster by modulating the immune system. So all of you know, COPD leads to chronic inflammation. Chronic inflammation leads to immune dysregulation. And then there's various cells, the monocytes, macrophages, etc., which are included under the ambit of immune dysregulation. We also know that immune dysregulation happens in the elderly. COPD happens in the elderly. So you've got a triple whammy effect. Old age, COPD, immune dysregulation bind together in increasing the risk of herpes zoster in patients with COPD. What about asthma? So in asthma, the impaired immune system increases the susceptibility to herpes zoster. And here, there is a depression of the Th1 immunity, and hence, there is reduced defense mechanism, and hence prevention of herpes zoster becomes important. So let's put this in perspective. Th1 immune response is responsible for reactivation of varicella zoster virus. Th1 is depressed in patients with asthma, and hence the prevention of herpes zoster in asthmatics becomes difficult. The other complicating factor with respiratory disease is a drug that you need to use in exacerbations often, especially in the elderly, especially in patients with severe disease. So corticosteroid use in asthma and COPD increases the risk of having herpes zoster. It also increases the risk of post-herpetic neuralgia. So increases the risk of herpes zoster, increases the risk of post-herpetic neuralgia. And this is shown in multiple studies. We have put up 2 studies there in front of you, one in asthma, one in COPD, where you see that there's a significant increase of relative risk in both these chronic diseases, asthma and COPD. What about the impact of herpes zoster on patients with COPD? So you're looking at it in the reverse way around, impact of herpes zoster on patients with COPD. And interestingly, risk of post-herpetic neuralgia in patients with COPD who develop herpes zoster is far higher. So this is a study which compared patients with post-herpetic neuralgia, people who have COPD, and patients who don't have COPD. And it was found that patients having COPD had a higher risk of developing post-herpetic neuralgia as compared to patients who did not have COPD. And understandably, the use of healthcare resources, the risk of using medical services is much greater in the population of patients with COPD and herpes zoster versus those who have herpes zoster but no COPD. What about impact of herpes zoster on patients with asthma? Asthma increases herpes zoster-related complications such as post-herpetic neuralgia and herpes zoster ophthalmicus. And again, this neat little study with a small number of patients, it's a dated study, but looks at about 8,000 odd patients, shows that there's a high risk of developing post-herpetic neuralgia in patients who have asthma compared to those who do not have asthma. What about the cardiopulmonary risk? So all of you know, and this is not within the purview of the discussion today, but all of you know that COPD and asthma, both diseases, are associated with cardiovascular events. This is more so in COPD, where the burden of chronic inflammation is greater, however, also happens in patients with asthma. There's a higher risk of stroke in patients with asthma and COPD. So the inflammation in COPD and asthma goes hand in hand with the cerebrovascular and the coronary events, hence increasing the risk of herpes zoster by multiplying the risks of cardiovascular and respiratory diseases. There's the mechanism on there which looks at lipid accumulation and macrophages. However, I won't go into the fine print there, but that's something for you to remember. COPD, cardiovascular disease, multiply the risk of both developing varicella zoster virus infections, so herpes zoster, and also post-herpetic neuralgia. And this is a similar study which looks at increased risk of stroke in patients with herpes zoster. What about herpes zoster recurrence in patients with underlying comorbidities? These are two different studies which looked at facets of recurrence of herpes zoster, risk of recurrence of herpes zoster, patients who do not have COPD, patients who have COPD but are not on inhaled corticosteroids, and patients of COPD who are on inhaled corticosteroids. And it shows that the recurrence rate in patients without COPD is lesser as compared to patients with COPD, be it on inhaled corticosteroids or be it without inhaled corticosteroids. So that's another important point. Inhaled corticosteroids do not seem to increase the risk of post-herpetic neuralgia. However, the occurrence of COPD does that. Herpes zoster tends to recur in these people. Keep this in mind, because when we discuss the indications for vaccination, these are facets that we'll bring out when we talk about the importance of vaccination in these individuals. So the last bit now, talking about treatment. So the treatment of acute herpes zoster is treatment with antivirals. However, treatment needs to be started ideally within 48 hours, latest within 72 hours of rash onset. This unfortunately does not happen often. It is not achievable because by the time the patients reach the doctor, the rashes have set in, the pustules have started appearing, and then use of antivirals is not usually successful. The other management, the conservative approach, is to manage the herpes zoster pain. And there are various strategies on that slide in front of you, which all of you know, which are used for management of herpes zoster pain. The most important facet, hence, would be prevention of the disease when there's not a lot of effective treatment available for it. And that is where the vaccine comes in. So herpes zoster infections and post-herpetic neuralgia prevention is done effectively with the vaccine in adults above the age of 50 years. The vaccine, which I'll talk about briefly, is a recombinant non-live adjuvant vaccine. So it's a recombinant non-live adjuvant vaccine. What's the mechanism of action? So the vaccine acts with the antigen, which is a 50 microgram molecule. It's normally attached to an adjuvant system. And the adjuvant system comes with a phospholipid bilayer, and there are immunostimulants attached to it. So there's the antigen, there's the adjuvant system. The adjuvanted form is attached to immunostimulants, and you can see the names of two immunostimulants, which you don't need to remember on that slide. Why do you need an immunostimulant? The immunostimulant is necessary because it evokes a much stronger and a broader immune response for individuals, and the immunity also lasts longer when it's in the adjuvanted form as compared to just the basic non-adjuvanted or the antigen form. So important to have the antigen and the adjuvanted portion, which is immunostimulants attached to each other, which gives you a stronger and broader immune response and a longer term response in individuals. There are two pivotal trials, which I'll mention briefly. They are called the ZO50 and the ZO70 trials. The primary objective, understandably, for both the trials was to look at vaccine efficacy in persons above the age of 50 when you look at the ZO trial, whereas the ZO 50 trial, whereas the ZO 70 trial, as the name indicates, was looking at herpes zoster efficacy, vaccine efficacy in people above the age of 70. The other thing I want you to remember from this slide is the dosing schedule of the vaccine used in the trial, and that's what we use in day-to-day clinical practice. So vaccine are administered intramuscularly at month 0 and then at 2 months. So at baseline and then 8 weeks after, you administered the second dose of the vaccine. And again, the vaccination schedule was similar in both the trials, the ZO 50 and the ZO 70 trials. Now, when you look at the two trials, so ZO 50 continuing up to 70, so 50 to 70, and then continuing beyond 70 for the ZO 70 trial, you can see that the vaccine efficacy across age groups is very similar and always uniformly above 90%. So that's a very effective vaccine. What about revaccination? So 4 years after the vaccine, you can see that the vaccine efficacy remains more or less at the same level. You can hardly see a drop in the immunogenicity in the vaccine efficacy. Across the board, across age groups, you have similar vaccine efficacy even after 4 years. What about side effects, deaths, so serious adverse events and deaths? There's hardly any reported and not much of a difference between the placebo arm and the vaccine arm. So that's about serious adverse events and deaths. What about the milder side effects, the adverse events which get reported but are milder adverse events? You can see the most common one is pain. It's not very severe. The study asked you to report any pain that happens, and the other ones are smaller in number, and they're mild to moderate intensity adverse events. The number of serious adverse events that I showed you a little while ago is insignificant. What about looking at different subgroups? So in ZO 50 and ZO 70, they did subgroup analysis across different comorbidities. So you can see the hypertension, dyslipidemia, diabetes listed. But I want you to look at the bottom of that particular bar diagram, and you can see asthma and respiratory disease, significant numbers together. They account for about 1,200 patients. And you can see the vaccine efficacy is well above 80%, so 85% in one and 88% in the other. So the respiratory disease as a comorbidity above the age of 50 would be an important indication for the administration of herpes zoster vaccine. What are the recommendations across the world? And you can see various countries globally listed out there. And across the board, rather than going to individual countries, you can see that the indication is approved for usage above the age of 50. And this is in accordance with recommendations which are available globally. The Gold 2024 report includes the CDC recommendation for zoster vaccine to protect against herpes zoster in adults aged 50 years and above with COPD. So there are other indications too, which you saw on there, but Gold recommends it as an important add-on treatment in the management of patients with COPD above the age of 50. Very briefly, this is the Indian data, which was no different with what was available globally. Good number of patients, about 288 patients who were enlisted over a period of 8 months. The vaccine efficacy was about 85.7%, which was the primary efficacy. They also looked at reactogenicity, the immunogenicity, which was also significant, was very good, and again, in line with the global data. So, zoster vaccine can be co-administered with the following vaccines. So, you've heard about influenza and pneumococcus. Zoster vaccine can be administered along with this, and also the Tdap vaccine, which is also a part of the recent Gold guidance from 2024. And you can see the Indian indication at the bottom, which we have spoken about already. The safety information from India is very similar to what's available globally. So you can see pain at injection site is mild to moderate pain in about 70% of patients. You have a bit of myalgia and fatigue and headache, which you get with most vaccines. These are mild in nature and do not last beyond 1 to 2 days. So that's my ambit. I think I'll stop sharing then, and my carry-home message for all of you is that this is an important add-on management in the elderly, in looking after patients who have multiple comorbidities, and the focus today is on COPD and asthma. And I think this is very, very important that we remember this vaccine along with the others, the influenza, the pneumococcus, the Tdap, when vaccinating the elderly in an Indian population. Thank you very much for listening.
Raja, thank you for a fantastic talk. You covered everything, really very, very lucid, very, very clear talk. Thank you so much. So we've had two fantastic speakers today who've told us so much about importance of shingles vaccine in pulmonary medicine. So I think we already have so many questions that have come up. Let's just start with question answers in the panel discussion. So first question to Vivek. So my two questions will be a little bit about the disease shingles, and then we'll talk about the use of vaccine in pulmonary medicine. So Vivek, over to you. So what is the difference between the infections chickenpox and herpes zoster, and what are the symptoms of herpes zoster?
So basically, chickenpox you would consider like the primary disease, and herpes you can consider as a secondary disease. This is caused by the same virus. Chickenpox usually happens more commonly in children, but now we see it in adults also. It usually starts with an upper respiratory catarrh-like symptoms like cold, cough, fever, associated with a vesicular rash. The rash is fluid, small blisters that develop more so in the truncal part initially to begin with, and then spread to the rest of the body as well. More commonly seen on the face, chest, and the genital areas. Herpes zoster so this is a typical cycle of the virus, the varicella virus, which causes it. And then following that, it goes into a state of, into incubation, not incubation. What is it called? It's
Dormancy.
Dormancy, sorry, yeah. It goes into a state of dormancy in the body, in the nerves, and goes and hides in the nerve roots. Later on to manifest as herpes zoster, which typically occurs in the form of rash in the dermatome. So at that time, there's no fever. Again, it's a vesicular eruption, but associated with significant pain. So the chickenpox rash is more which finally goes into a scabby phase and is associated with itching, whereas herpes zoster rash is associated more with pain. In fact, there are times when it starts with pain and the rash evolves later. There are times when patients come to us with chest pain and you start evaluating the various causes. At that time, there is no rash, but there's significant pain. And the pain actually sounds very similar to the pleuritic chest pain because it is localized, one area. And a day or two later, you realize that the rash has appeared and that was the cause of the pain. So that is how you differentiate between the two rashes.
Okay, very well said. Very, very important that we know what herpes zoster begins as. And I think this was important that very often pain comes up before the rash because it's important for us to start treatment, as Dr. Raja said, as early as possible, not later than 72 hours for sure. So thank you, Vivek, for this. Now, I'd like to come to Dr. Raja. So Raja, let's talk about, you have already told us once, but just as a revision for people to know, which dermatomes are most commonly affected by herpes zoster? And what are the complications of herpes zoster?
Sure, Amita. So, thoracic dermatome, as we said, which is just about 50%. So, thoracic dermatome is affected in about 50% of cases. I remember that the cervical and the lumbar is somewhere between 10 to 15%. I think that's an easy way to remember. Whereas the sacral is the smallest percentage. It's less than 5% of cases that the sacral dermatome gets affected. The complications, so the most important one, the one which we spoke about at length, is post-herpetic neuralgia, which is causes the most amount of morbidity. It's not a life-threatening complication, but it causes a lot of morbidity. There are other complications. So herpes zoster ophthalmicus is one, which can result in blindness, like we said. Facial nerve palsy can happen in patients with Ramsay-Hunt syndrome. There's the encephalitis, the meningitis, retinitis sometimes, and other neurological complications. And rarely and interestingly, there's some patients present with post-herpetic pruritus. So that's another complication that's sometimes spoken about.
Okay, great. So Raja, very, very important. Thoracic dermatome is most commonly involved. We need to know this. And the complications, which we are not even thinking about, are actually very, very important. Encephalitis, a very important one. Okay, fine. So now I'd like to come to Dr. Vivek. Which conditions increase the risk of getting herpes zoster, and how do asthma and COPD increase the risk of herpes zoster?
So I think first thing is that any adult more than 50 years of age would be more prone to developing herpes zoster, and that is because of the immunosensus that happens in the adults. So what happens is that this virus continues to be in a dormant state in our body, in the latent phase in our bodies, just like latent tuberculosis does. And then one day it just manifests in the term of this pain and painful rash along a particular dermatome. So this obviously, as simple logic would say, that this would happen anytime when the immune system is weak. That may happen with age, that may happen with any kind of comorbidity which can reduce the immune system. And those would be in terms of diabetes, in terms of those on long-term immunosuppressive therapies, chemotherapies, development of HIV, development of any other immune compromising condition that could result in a lower immunity. And as a result, this latent virus would then start proliferating. COPD and asthma and the use of corticosteroids also does the same thing. It basically reduces the immunity. Raja has already explained it very well in his talk, that how COPD and asthma can impact the immune status of an individual, resulting in an increased probability of then developing herpes zoster. Overall, it's because of the decline in the antibodies, the T cell responses. There's a suppression of the Th1 response because of in asthma patients, decrease in the NK cells. All of that collectively would result in an increased probability of an individual suffering with COPD and asthma to develop herpes zoster.
Okay, great. So this is very important. So anybody who is on immunosuppression, like Dr. Vivek said, so may it be steroids, may it be any methotrexate or any kind of other steroid spares or any kind of chemotherapy, probably also patients who've undergone a splenectomy and patients of diabetes, as you already said. So these people are really very, very likely to get herpes zoster, and we need to cover them. So Raja, coming to you. What is the impact of herpes zoster on patients with COPD?
So I think I remember, I'll sort of keep this simple. 3 facts I think are important to remember when you think about herpes zoster in patients with COPD. The first is that the incidence of post-herpetic neuralgia is greater. So that's one. Second, I spoke about the economic impact and also, of course, the morbidity associated. So chances of COPD patients with herpes zoster getting admitted to hospital is greater. So the chances of hospitalization are greater. And third, the virus can act as a trigger for COPD, and hence it could be a cause for an acute exacerbation of COPD and hence result in a hospitalization.
So, Raja, this was very, very important because, the thing is that very often we may feel that by vaccinating our COPD patients with the shingles vaccine, what we are doing is that we are preventing the pain of going, pain that we go through herpes zoster.
Sure.
But what is really important that we need to know is that we are not preventing herpes so that it causes pain and post-herpetic neuralgia. We are most importantly avoiding the chance of acute exacerbation of COPD and a COPD patient requiring hospitalization. So it actually improves the outcome of our patients, unlike what we may feel that it reduces the chance of herpes and therefore pain. So very well said, Raja. Important. And I want everybody to please make a note of this. This is very important. So now coming to Dr. Vivek, something very similar. What is the impact of herpes zoster in patients of asthma?
So basically, again, the same thing, when a patient of asthma develops herpes zoster, one, of course, there would be increased pain. Post-herpetic neuralgia will be more common in these patients. But also what happens is that, if they have been on long-term steroids, you'll have to reduce the steroids and the asthma may flare up. So that there's a total disbalance in the management of asthma also. Although inhaled corticosteroids do not result in increase in the development of herpes zoster, but the oral corticosteroids definitely would. So there would be a total disbalance, and the management of asthma also will become complicated in such a situation.
Right, very well said. So the thing is that again, the asthma outcomes also may get affected, and very importantly, during acute herpes, we may have to reduce the doses of steroids, which could be harmful for our patients of asthma, which can actually lead to exacerbation. So very important. Thank you, Vivek. Coming to Raja. So can herpes zoster recur in a patient who's already had herpes in the past? And will it recur in everybody or a particular group of patients? Please tell us.
Yeah. So, Amitabh, it's about 5 to 10% of people who can get a recurrence of herpes zoster. This is more common in people who are immunocompromised. It's also more likely in the comorbid population. And in the comorbid population, we spoke specifically about COPD and asthma increasing the risk of recurrence of herpes zoster. So immunocompromise and chronic respiratory disease, I think, are the two ones which are important to remember.
Yeah, so again, very important because very of us would feel that, okay, once the herpes ho gaya, it won't come again. But it is known to happen in 5 to 10% of patients again. And COPD and asthmatics have a higher chance of getting it. So this is again very, very important information being given by our two fantastic faculty. I'd like to come to Vivek now. So something very close to your heart because you're so much into infections and vaccines. So how should we treat the disease herpes zoster, including the neuralgia? So patient wasn't vaccinated, unfortunately, and he got herpes and his terrible pain. What to do, how to manage?
So basically, in this situation, the antiviral needs to be started as quickly as possible and preferably within 72 hours of the rash onset. As I said, sometimes in patients, there is such significant pain preceding the rash that unfortunately you're not able to diagnose it in time. But as soon as the rash appears, you must start the treatment. The rash is very, very typical. It's a vesicular eruption that occurs along the dermatome. The pain is also along the dermatome. And so you should start the antiviral treatment with acyclovir as an option, or famciclovir, or valcyclovir. Any of those medications can be started in the patient.
Yeah.
But please always check the renal functions from time to time. Day 1, day 4, day 7, you must check the renal functions. I've had a patient in my own family who had CKD, diabetes, and was started on antivirals after the development of herpes zoster, went into kidney shutdown, had to be shifted to the ICU, underwent dialysis, and 2 days or 3 days later, we lost that patient. He was my own uncle. So since then, I'm very, very careful with the renal functions, which must be checked when you're starting an antiviral therapy. Also, maybe the analgesics might have contributed to it to some extent because invariably the patients tend to start taking the ibuprofen paracetamol combination, which again should be avoided. One should rely more on anti-inflammatories like paracetamol or drugs which are recommended for the neuropathic pains like the pregabalin and gabalin, which are relatively safe in use. So those are the medicines that you would rely on as far as management of herpes zoster is concerned. Remember always, this pain of herpes zoster is probably considered to be even more severe than the labor pains that women experience. I've seen patients where with herpes zoster only on the face that they can't even, tolerate the breeze that is outside. So they want to remain indoors all the time. The pain of herpes zoster can be really very severe and very, very debilitating.
Yeah, very well said. So as Dr. Vivek rightly said, I'd even like to complete the doses. So acyclovir, we either give 800 milligrams 5 times a day, or we can give valcyclovir 1 gram 3 times a day for 7 days. So very, very important, we give complete doses. Checking renal function, very, very important. Very important point given by Dr. Vivek, because we often miss out on that. And also very important point that patients often self-medicate with NSAIDs before they come to us, and therefore checking creatinine is important. And nerve medications, gabapentin, pregabalin. If you want to give gabapentin, then you can actually give the full dose, which is up to 1600 milligrams a day. Or we can give a pregabalin, which is, up to 300 milligrams a day. If they can't sleep in the night, then giving tryptamar would help. Very often, tramadol works better than NSAIDs. So this is what, and also applying cold stuff makes them feel happy. And what Dr. Vivek said was very true, because my patient used to say, "Hawa ka joka aata hai aur rone ka man hota hai." So I think the blast of air is extremely painful for them. Raja, were you trying to say something? I thought.
I was going to ask something to Vivek or maybe to you, Amita. So I think one of the challenges we have is when the pain happens in the elderly and patients with respiratory. So what drugs would you use in that scenario? I mean, people with COPD, post-herpetic neuralgia. So we're not talking about chickenpox here, but about sort of post-herpetic neuralgia. Would you go for the pregabalin and the gabapentin? Would you be more cautious with respiratory depression, etc.? Would you go for Tramazac, etc.? What would be your cocktail for people with chronic respiratory disease, maybe low saturations? What would you use? Because that's a challenge, I feel.
Okay, so Vivek, you want to answer first?
Yeah, absolutely, Raja. I agree with you. So there you would start with a lower dose, like pregabalin 50 mg for 2 days, 3 days that the patient tolerates it, then increase it to 75 mg, and then go on increasing subsequently. I'm not sure what is the role of nerve blocks in these situations. That is something that one can consider if you're not able to, if you're limited by the dosages because of the type 2 CO2 narcosis or something. But I guess the options are very, very limited.
Yeah, I think
Sure.
Raja, as always, a fantastic point raised by you. So I basically just feel that preferably I'll try to start pregabalin or gabalin during daytime, and I'll actually repeat an ABG after 4 to 6 hours and make sure that the PCO2 is not going up. But I feel that with gabalin, pregabalin, the rise in PCO2 would be much less than we would see with Tramazac. So, and I think that probably local applications, we have things like ice gels, etc. So locally, if we can make them feel cold, then very often it actually helps them. And I think we'll have to be very, very careful. Tryptoma we'll definitely avoid in these patients. And I think nerve block could be a very important use over here in these patients. So fantastic. So it's
Yeah.
very, very important that we prevent shingles, then have to do all these for our patients. So Raja,
Yeah.
coming to you, in which patients do we recommend the herpes zoster vaccine? Who should be vaccinated by us for herpes zoster?
Yeah.
Us and by GPs.
Yeah. So I think for us, it's patients above the age of 50 with COPD or chronic asthma or the overlap syndrome. I would even do it for interstitial lung disease, even though it's an extrapolated evidence, I think, but I would extrapolate that bit of evidence. I don't think we'll have evidence in ILD. For the physician, I think you would do it for all comorbidities above the age of 50. So I showed you some data in diabetes, in cerebrovascular, in coronary disease. So I don't think it's any different to what it is for influenza and pneumonia. It's above the age of 50, and you would do it for any comorbidity which is causing significant impairment and requires treatment.
Yes, very well said. So COPD, asthma, definitely, overlap syndrome, definitely, and any patients who are on steroids for whatever reason. So it could be ILD, or even if we are not using steroids in IPF, it would be definitely worth giving it to them. And as Dr. Raja said, any patient on any kind of immunosuppression, which may not be for COPD, asthma, so whether it's for steroids or it's biologics or immunosuppressive agents, or patients who have CKD or splenectomy, etc., we have to. Basically, even a lot of people are suggesting, it's not still in our country, but as per CDC, anybody more than 50 years of age could actually be given the shingles vaccine. So great answer. Thank you, Raja. I'd like to come to Dr. Vivek. So we all know that we should ideally be vaccinating our patients more and more, unlike what we are not really doing against the shingles vaccine. So what is the efficacy of the herpes zoster vaccine?
So efficacy in the age group of more than 50 years is almost touching 90%, and you can't expect better than this. And even in patients with asthma and COPD, as Raja had shown in his slides, is almost over 80%. So again, this is way better than the influenza or the pneumococcal efficacy, the pneumococcal vaccine efficacy that we get to see. So this is one vaccine which I feel we should strongly recommend to our patients, primarily because it has a very good efficacy and herpetic neuralgias can be very, very debilitating.
Wonderful. And also another point, when we give flu shot to we give pneumonia shots, basically we say we can't prevent the infection, but the symptoms will be less and the severity will be less. Whereas when we give the shingles vaccine, we are preventing it from happening altogether. So that is again, I think, a huge strength of this vaccine. And more than 90%, as Dr. Vivek said, is brilliant. It is absolutely very state of the art. Raja, coming to you. What are the common side effects? Now that we know we need to give the vaccine, we rather know what are the common side effects. You told us during your talk, but if you could please repeat once more.
I think if you broadly divide, like any other vaccine, if you broadly divide them into serious adverse events and the mild to moderate adverse events. So the serious adverse events which result in hospitalization or mortality is very, very few. And in the ZOE trials that I spoke about, the numbers were no different to what it was in the placebo arm. So the serious adverse events box is ticked, and there are almost no
We lost Dr. Raj. I think poor
pain at the injection site. So I think that's one which is important. Other ones, the redness, the swelling, myalgia, headache, etc., are present in somewhere around 10 to 30% of cases. But again, it's no different to what it is for other vaccines like influenza, pneumonia, hepatitis, and so on and so forth. So the adverse events are there, but they are mild to moderate, and they don't last beyond 1 to 2 days in most cases.
Wonderful. So just like any other vaccine, as Dr. Raja said, and the advantages are tremendous as against that. So Vivek, coming to you, you told us about the efficacy of the herpes zoster vaccine worldwide, which are amazing data. I believe there's also a study going on in India. So can you tell us what is the efficacy of the herpes virus vaccine that we've seen in our country?
So basically, this was a phase 3 study that was conducted, which included about 288 Indian subjects over a period of 8 months. And the RZV vaccine was found to elicit a very robust immune responses in adults more than 50 years from India and demonstrated a very acceptable safety profile. So, safety as well as efficacy, both have been proven beyond doubt in the Indian population.
So wonderful. So equally effective, 90%, and equally safe as the other trials. So very good. This is very, very promising. Raja, coming to you, you told us that, patients on corticosteroids, and we all know also should be receiving the vaccine, herpes zoster vaccine. So is it that the patient should be on a particular dose, or everybody should be given the vaccine?
So I think there's very good data, like we discussed before, that patients who are immunosuppressed on, say, steroids or other immunosuppressants, the risks are multiplied many a time. So the risk of getting post-herpetic neuralgia, the chances of getting recurrence, the chances of getting hospitalized are all greater in that population of patients. Hence, bottom line is you need to vaccinate people irrespective of the dose. However, if you had an option, if you could reduce dose, you would want to reduce it to below 20 milligram before you vaccinate these people. So the carry-home message is vaccinate. Ideally, vaccinate at a dose of below 20 milligram is the carry-home message for our audience.
Wonderful. Very, very specific. And this was, I think, very important information, because if we feel that our patient is going to come down soon on the doses, then we rather give it when the dose is less than 20 milligrams. But if you think that patient has a condition in which 40 milligrams or more than 20 is going to continue for a longer period, then please vaccinate as against not vaccinating. Vivek, a very important question, which a lot of audience have also asked us, and we have more than 20 questions already. So this is a very important question, Vivek, that along with the herpes zoster vaccine, recombinant herpes zoster vaccine, what other vaccines can be given in the same setting? It's very important because, we normally give the pneumococcal vaccine and influenza vaccine same time so that we know it's done. So is there something that we have to be careful not to give this particular vaccine with the herpes zoster vaccine, and what can be given with it?
See, basically what we need to understand is that two vaccines which have a different platform on which they've been manufactured can easily be given together. So like RZV is a recombinant vaccine, so it can be given with influenza vaccine. It can be given with pneumococcal, both polysaccharide as well as conjugate vaccine, because there's a conjugate vaccine and that's a recombinant vaccine. And then it can also be given with Tdap, except that they should be given in the different arms. So 2 different arms when you're administering it.
Okay, again, this is very important information. So we can give it with the pneumococcal vaccine, we can give it the Tdap vaccine and the influenza vaccine, all the vaccines which we would normally like to give to our COPD patients. This is very important because somewhere I had heard somebody say that you can't give it the pneumococcal vaccine, but it can be given. So,
but what I'm doing with most of my patients is usually we give them the influenza and the pneumococcal vaccines in the springtime, autumn time now, September, October. So what I'm doing is I'm giving them the benefit of influenza and pneumococcal vaccine in September, October, and the Shingles vaccine during the summertime when there's no other vaccine being given to them.
Okay. So actually, at least in Mumbai, we prefer to give the flu shots in April, May. So that is what we are doing in Mumbai, April, May. And I'm still I'm giving flu and pneumonia together, usually the flu vaccine and the Prevnar 13 first. And after 2 weeks, I'm giving them the shingles vaccine. That's what I'm doing. Raja, what are you doing? I think Raja's reception is a
In
little
Southern
yeah.
Hemisphere. My reception is poor, is it? I'm so
Yes.
sorry.
In
Can you
between,
hear me now?
yes. Now we can hear you. Yeah, we lost you in
Okay.
between.
Okay. So I think there's this question of Northern and Southern Hemisphere with the vaccine. So we, like Vivek, actually vaccinate sort of August, September, October time. And I would normally vaccinate at the same time. So I would give them not on the same day, but I would try and give the influenza and the pneumonia club together. And I would give the shingles soon after. So I would give it after 7 days, 10 days, 14 days, so that the vaccination is complete short span of time rather than spanning over a long period of time. So that's what I normally do.
Yes. One very important point for the audience, if your patient is not vaccinated, if he has COPD, then please vaccinate that time only. Don't wait for the preferable months to come. And I think it'll be good that we give the flu and the pneumonia vaccine together like all of us are doing. And maybe 2 weeks later, we can give the shingles vaccine. I think maybe that could be done. So great. This was very important clinical point. Thank you so much, Raja and Vivek, for this. So Raja, coming to you. How long will the protection last once you give the herpes zoster vaccine? And is any booster required?
Yeah. So I think the studies have shown and CDC recommends that, like I showed in the study, 90% vaccine efficacy is maintained beyond 10 years. So that's the data we have. We don't have data beyond that. So as of now, CDC does not recommend a booster after 10 years or 15 years. That's data that has to emerge. At the moment, it's 2 doses, the 0 dose and the 8-week dose. That's all we do. We don't have data to give a booster beyond that time period as of now.
Okay, so again, very, very important that give the first dose. The second dose is after 2 months. And as of now, we don't have to give a booster. So this is important information. We don't know if guidelines will change, but as of now, only 2 doses and no booster after that. Vivek, coming to you, a very important question that basically if a patient is suffering or has got herpes zoster, then for how long so first of all, should they take the vaccine again or not? And if they should take the vaccine again, then how long can they wait before they take the shingles vaccine?
So basically, shingles is one disease which can recur and not recur once, but recur quite often in times to come. Therefore, it is important to give the vaccine to even those who've suffered with the shingles disease. So what do? You basically wait for the acute phase of shingles to be over and then give them the vaccine. That could, some people even say after 2 weeks, once the lesions have dried up, it's safe to give the vaccination shot. But CDC recommends that you wait for at least 2 months after resolution of the acute lesion. And the NACI, that is the Canadian Society, suggests that waiting for a year after the episode for giving 2 doses of RZV. But yes, I think American guidelines are more reasonable that as soon as the lesions are 2 months later, after the acute phase is over, you can give the vaccine.
Yeah, I think I agree with the American guidelines. 2 months would be quite reasonable. And I also believe that because herpes zoster is a viral infection, the immunity is reduced after any any viral infection. So maybe waiting for a period of 8 weeks would be good. So I think after 2 months, we should vaccinate. If the patient gets shingles, after 2 months of recovering, we can definitely give it to the patient. Raja, coming to you. So we have many diseases which are, vaccine preventable diseases. So these vaccine preventable diseases sometimes may be life-threatening, or sometimes they are not life-threatening, but they are vaccine preventable, and they may have a lot of morbidity, if not mortality. So which are the diseases that you think must be vaccinated even if they don't kill us?
Yeah, so I think you mentioned this a little while ago, Amita, very appropriately, that influenza and pneumonia are vaccines which reduce the severity of disease rather than preventing disease in a large majority. We've seen that even for COVID-19, when people have been vaccinated for COVID-19. So I think the gold body for sort of COPD and other bodies in the world had a paradigm shift when they started recommending vaccines for diseases which cause a lot of morbidity, even if they don't cause mortality. And the 2 vaccines that came in at similar sort of time was the shingles vaccine and the pertussis vaccine or the Tdap vaccine. So those are two diseases which cause a lot of morbidity. Pertussis in the way of the distressing cough, and zoster in the way of the post-herpetic neuralgia, which all of us have spoken about, and other complications, where you prevent morbidity rather than preventing mortality, but do it effectively in about 90% or more number of cases. And hence, they are vaccines which should be given to people at risk. And we have spoken about the risks as we have gone along in this meeting.
Yeah, so wonderful information once again that these diseases may not be killer diseases, but they actually affect the quality of life. And our respiratory patients are already living a life which is, often restricted, the mobility is restricted, etc. So, reducing further kind of quality of life affection by giving vaccinations against shingles and Tdap would be, I think, really good. We have more than 30 audience questions, so I'll just quickly take them. Let's see how many we can cover. So Vivek, coming to you. There's Dr. Rida Khan asking from Mumbai, should Shingrix be given to patients who've already got shingles in the past? You just answered, but quickly a one-line answer.
I think it should be given as soon as the acute phase is over or 2 months have passed by. You should give them the vaccine.
Wonderful. We have Dr. Bhavya asking from Mumbai, can Shingrix be given for people taking immunosuppressive agents? And
Yeah.
at what dose?
Yeah, so I think we answered that, but it's a very important question. So patients who are on immunosuppressive, including steroids, need the vaccine. Ideally, if they're on steroids, the dose of steroids should be less than 20 milligrams when you vaccinate them. But it's important to vaccinate. Even if you cannot reduce it above below 20 for whatever reason, you should still vaccinate them with a slightly higher risk.
Okay, great. We have Dr. Krishna from Pune who's asking, how long does the Shingrix vaccine protection last against shingles? Vivek, can you take this, please?
Yeah, so approximately 88% of the efficacy is maintained even after 11 years of giving the shot.
Right, very good. And just adding to what Dr. Vivek rightly said, and as of now, we don't give a booster. So fine, right. Okay, we have Dr. Anand who's from Lucknow. Dr. Anand is asking, Raja, this is for you. Can Shingrix be given to people with chronic conditions like diabetes or heart disease?
Yes, I think this is, again, very important. I spoke about it briefly during my talk, the fact that herpes zoster can increase the risk of vascular problems, be that cerebral or be that coronary. And hence, people who are diabetic, people who have ischemic heart disease, people who have cerebrovascular disease, kidney disease, very, very important to vaccinate them as per the indications we've spoken about in that population of patients.
Absolutely. This is just basically, I feel this webinar is so important because, all our pulmonologists know that we need to give it for COPD asthma, but probably we may not have thought about giving it to patients or even recommending to our relatives who have IHD, who are more than 50 years of age. So I think very important answers are coming from these wonderful questions. Vivek, one question for you. This you've already answered. Dr. Shilpa Sharma from Delhi is asking, how long Shingrix protection lasts after the shingles? The vaccine protection is for how long? So,
About
Dr.
11 years.
It has already 11 years. So, Vivek, one more question for you. Dr. Sudeep To from Kolkata is asking, are there any age restrictions for giving the Shingrix vaccine?
So anybody above 50 years of age can be given?
Okay, great. So more than 50 years of age is the cut line. We don't give it to people who are younger than 50 years because the immunity remembers till 50 years of age, the initial infection. And therefore, we give it after the age of 50 years. Wonderful. Thank you, Vivek. Raja, coming to you, a very interesting question. Dr. Sanket from Nagpur is asking, you all spoke about the interactions between Shingrix and other vaccines, but what about COVID-19 vaccine? Any interactions in any time period?
Yeah, so Sanket, I think there are no interactions. This is a non-live vaccine, as we said. So there should not be any interaction with the COVID-19 vaccine. But I wonder where you're getting your COVID-19 vaccines just now, because I don't seem to find them in Kolkata at all. So I don't think I have the risk of causing any interactions anyway, because we are not vaccinating for COVID-19 anymore. But I don't think there will be an interaction.
Okay. I think probably this question might have been asked because, the gold guidelines still mention giving COVID vaccine, in the guidelines.
Yeah.
So,
yeah, it's a soft indication that they have talked about, Amita. And I think
we will not give ever.
Yeah.
Absolutely. I feel
but they can be given together. Even the CDC has stated that they can be given together.
Okay, great. Thank you, Raja and Vivek. Vivek, coming to you, we have wonderful questions. It's quite interesting. So, Dr. Shikha Jindal Gupta from Delhi. In fact, she was in our last week's webinar and she was fabulous. So she's asking, Vivek, this is for you. Is chickenpox vaccine same as a herpes zoster vaccine?
No, not really. Chickenpox vaccine is a live attenuated vaccine, whereas herpes zoster is a recombinant vaccine, and the concentration is much higher in the herpes zoster vaccine as compared to the chickenpox vaccine. Although it's again the same virus, but there's a difference between the two.
So, I'll give you this again in continuation. There's a question from Dr. Varsha, and Dr. Shikha has also asked the same question, that if the elderly patient is vaccinated with chickenpox, then do we need to additionally give them the herpes zoster vaccine? I think very important questions. Vivek, what have you got to say?
So elderly patient vaccinated with chickenpox, that means they would have received the chickenpox vaccine recently. So
Right.
this I am not sure of. If somebody at the age of 50 years is receiving a chickenpox vaccine, should he be receiving the chickenpox vaccine or the herpes zoster vaccine is a question. So, in that situation, you might as well give the herpes zoster vaccine, the Shingrix, rather than giving the chickenpox vaccine.
Okay. This is interesting, but I'm not sure. I'm just assuming that maybe some people were lucky abroad who didn't get chickenpox. And maybe, if chickenpox occurs later in life, it's more harmful. Maybe
Yeah.
chickenpox vaccine would be given to an elderly person.
I mean,
Raja,
I'm not sure. So I think the question is, if someone has received the chickenpox vaccine in childhood, do they need the shingles vaccine in adulthood is the question above the age of 50, which is being asked. And like all of us have said on the platform, I think you would require the shingles vaccine in adulthood beyond the age of 50 in the right sort of indication, even if you receive the 2 doses of chickenpox vaccine in childhood as per
Yes,
the
the
international
question was
guidelines.
very
So
specific. If an elderly patient is vaccinated, so probably maybe the patient, okay, maybe. So in childhood received the 2 vaccines of chickenpox, and now
correct,
they've turned elderly, then also
correct,
they have herpes.
correct. Yeah.
Correct. Okay, fine. Great. So I think a lot of enthusiasm in our audience. Wonderful questions are coming very out of the box, making us think. That's great. Raja, over to you. We have Dr. Anupama who's asking, should we give vaccine in patients on steroids in asthma or in patients with other comorbidities in COPD?
Yeah. So, Anupama, I think that's a great question. We've talked about the steroids bit a few times now. So, steroids, yes. Ideally, a dose of less than 20 milligrams is when you give the vaccine. The other important question, which we mentioned briefly, was if you have multimorbidity. So, if you have 3 comorbidities, you have COPD, you have diabetes, you have ischemic heart disease, it's triply more important to vaccinate these people because these risk factors add up, they stack up and increase your risks of getting herpes zoster and also the post-herpetic neuralgia that comes with it.
Very good. Very, very good. So basically, any comorbidities more than 50 years of age, especially respiratory patients, always please give it the vaccine. Vivek, over to you again. Interesting question from Dr. Suresh Kumar from Hyderabad. Can persons who've had zoster, can a person have herpes zoster without suffering from varicella infection in childhood or adulthood?
Yeah, certainly he can. Varicella zoster, of course, initially it was thought that somebody who's had chickenpox cannot have varicella zoster later on. But now we know that, in fact, people who've had chickenpox in childhood, that is where the virus would go dormant and then reappear later on in adulthood. But there can be people who can just have a dormant disease all through and then manifest only in adulthood. So this is also known to happen that people, in fact, that is what is more commonly seen, that people who've not had chickenpox earlier develop herpes zoster in the adulthood.
It's a very important point by Dr. Vivek that even if the patient is sure that they never had chickenpox in the past, if they're more than 50 years of age and if they have comorbidities, please definitely give them the shingles vaccine. Okay, Raja, coming to you again, interesting question from Dr. Ravinder from Chandigarh. He's asking, patient who has recently suffered from herpes zoster, is the vaccine useful for them? And what is the duration after which you could give? We've discussed, but Raja, if you could tell again, because the question is recently asked at 9:30. So
Sure. No, I think it's a terrific question, Dr. Ravinder. So if you've had herpes zoster recently, you would vaccinate these people because there's a 5 to 10 months of recurrence. However, if you've had the disease, you're going to have the antibodies for a period of time. And that period of time is normally thought to be about a year. So beyond a year, you can think of giving the vaccine in people who've had a herpes zoster infection after the age of 50.
Okay, wonderful. Thank you, Raja, for again reiterating the same so that we make sure it's reinforced. Vivek, coming to you again, interesting question, which we've answered, but it'll be nice if you answer this. So you Dr. Nilesh Shah from Ahmedabad, and we have Dr. Atul. They both are asking that normal individuals more than 50 years of age who don't have comorbidities, who are healthy, should they also be recommended the shingles vaccine?
Yeah, absolutely. Because of the phenomena of immunosenescence, where you expect the immunity to be coming down after 50 years of age, and it has been seen that people after 50 years of age are more prone to developing herpes zoster. Therefore, it is important to vaccinate them after 50 years of age. So it is a strong recommendation for sure.
Absolutely. Very well said. Raja, what do you, I was about to ask you, what do you want to say?
So I was just going to add that while I completely agree with what Vivek said, this is outside the guidelines we are talking about. So the vaccine should be offered. It, however, needs to be discussed with the person that we are offering them this without a guideline which exists at the moment. Neither the CDC nor the Indian guidelines speak about this. But I think it's a very good, important measure to offer it to people above the age of 50, even if they are healthy. But it's an out-of-the-box indication as things stand today.
So, I'd like to make an interesting point, because the thing is that I have actually been recommending for people who are more than 50 years of age with a comorbidity. And then very often I've been meeting, when I go out, I meet these fancy people, and they just say, oh, doctor, I'm trying to take the Shingrix vaccine. What do you suggest? And I'm already 50. And then I ask them, do you have this, have this, have this? So they don't have anything, but they have these GPs who are a little high profile, and they always recommend it should be taken. So I was actually thinking initially I was thinking maybe it's an overkill, but now I feel that probably, it's worth offering it to them. And as Dr. Vivek said, it would probably be worth offering it to them or telling them about it. And as Raja said, definitely we have to tell them about the caution that still not recommended, but please consider. So after
I agree completely, Amita.
Yeah. So after the age of 50 years, definitely if you recommend, please say that it would be better, but the
Same
guidelines
page, yeah.
don't say it. Probably soon it will come into the guidelines. But if any comorbidity of whatever sort in a patient more than 50 years of age, we have to give the shingles vaccine. Please remember that. So there are about 7 to 8 more questions, but we have just taken them already. So then we will not go through them again. So we've had about 33 questions and we answered all of them so quickly. So I think it was wonderful, like a rapid buzzer round, fantastically done by both our brilliant faculties. So I would like each of you all to give some message, a take-home message about shingles vaccine to our audience. Vivek, over to you first.
Yeah, I think we have been underplaying the vaccinology in our practice. It is high time we realize the importance of vaccines in preventing such severe infections like herpes zoster. Herpes zoster may not be a life-threatening infection, but can really cause severe debility and huge morbidity and impact the management of various diseases, especially COPD and asthma. Therefore, we must keep this on a priority and offer it to all our patients. The way we've been offering influenza and pneumococcal vaccine, it's high time now. We should start offering them the Shingrix vaccine as well.
Wonderful. Very well said. Raja, over to you.
So we'll cross borders. So I'll go into Vivek's territory and his talk and give you a message about adult vaccination. I think, like all of us have said, I think it's important to think about the adult vaccination umbrella like we think about childhood immunization. Unless we think there's a degree of compulsion involved in it, unless we have government guidelines which recommend it, it is getting more and more difficult to promote this amongst physicians, amongst GPs, amongst other specialties. And I think it needs to have a concerted effort from all our sides to make sure adult vaccination is promoted in every platform there is. So for all of us who are listening to us, please promote adult vaccination. Make sure your patients are getting vaccinated in every disease that we have spoken about today, including shingles vaccination.
Very well said, Raja. And I would like to tell everybody that Dr. Raja Dhar is actually responsible. He was the captain of the team which made adult immunization guidelines in pulmonary practice for our country. And it is so heartening that under Raja's leadership, we are looking forward now to adding shingles vaccine in and completing our guidelines. So soon you all will have a newer version of the guideline, which will also add shingles vaccine in our pulmonology practice officially from our Indian Chest Society. And I would like to say this was fabulous. Vivek, Raja, both of you all were phenomenal. Both the talks were extremely enlightening. They were very, very lucid. extremely interesting and informative. And I thought the question answer sessions were so important. I myself had learned so much, and certain things that I was not really sure about, I've got confidence in doing or not doing it. So we are getting wonderful feedback from our audience about the webinar, and I think everybody has really enjoyed listening to our faculty and discussing the questions. And I'm extremely grateful to our audience for this wonderful participation by asking so many questions and making sure that we feel good that we have tried to make a difference. We have a very good step today. We have decided that we want to do a survey, and we have a few questions, 5 to 6 questions, and we basically want to know if you all have learned anything new or if our webinar has made a difference to you all. So I request everybody to just wait for a few minutes, and tech team, can we just have the survey questions, please?
And before that, Amita, big thank you to you. Wonderfully well moderated. Really enjoyed doing the program. Thank you, Vivek, and
Absolutely
thank you to
beautifully
GSK for
moderated.
putting
Thank
this
you,
together.
Raja, for joining in despite your other commitments and despite all the chaos that must be happening in Kolkata right now.
Yeah,
Yeah.
in fact, people don't know, but Raja has been so active, and I would say he's so brave, to be really leading even the protests over there, giving interviews. He also got invited by cyber police for talking against so whatever. I mean, I think it requires a lot of guts and a lot of commitment, and we all feel so much for what has happened, but to be there, at ground zero and contributing so much, Raja, that is simply wonderful.
Thank you.
In the
I
midst
think it's great the entire country has come together in this, and I think it's important that we stay together because it's an issue which is common to all of us. I think it is something which all of us might suffer from if we have not done already. So I think it's an important issue that needs to be highlighted. So thank you to both of you for bringing it up. Thanks, Amita.
Yeah, thank you. So quickly, the survey, and then I'll say a thank you to everybody. So can we
Yeah.
have the survey questions, please?
So, ma'am, survey question is already shorted on the back end, so it will be
Okay,
visible
okay.
to the live webcast users. So they
Okay.
will take a minute or two to submit the responses, ma'am.
Okay, fine. So I'm sure, we'll inform everybody about if the webinar has made a difference or not. But I'm sure, with the number of logins that we've had, I'm sure we must have definitely made a difference. And today, for a change, after we put up the webinar flyer in all the groups, we got so many comments which kept on saying, thank you for the topic. We want to hear so much. We're always learning more and more. So I think it was good to include this topic. Thank you, Raja. And thank you, Vivek, for
Thank
this fantastic information. I think it has been a wonderful webinar. And as I said earlier, we were lucky to get the best faculty of our country tell us on a topic which we don't know much about. And they have told us everything that we need to know about the topic. So huge big thank you to Vivek and Raja for always leading from the front. A huge big thank you to our Indian Chess Society, Dr. Sandeep Salvi, our president, Dr. Raja Dhar, secretary, and our entire governing body for always making sure that we are trying to improve the pulmonology academics and pulmonology knowledge in our country. And a huge big thank you to our academic partners, GSK, and our two GSK doctors, Dr. Yashpal and Dr. Ashfaq, for your fantastic inputs and support, and to our tech team for being absolutely flawless. Thank you so much.
Thank you.